how about I let you guys read this on your own, so you can read this at your own pace, and then we'll chat a little bit about it, okay? Does anybody mind, real quick before you get started, talking about this, does anybody mind dropping the SOAP note form, the link for that Google Drive, Google form in the chat? If you could do that, that would be awesome, just so that I don't have to exit out of the presentation. Great, awesome. Thank you so much, Matt. Okay, well, hopefully you guys got a chance to read a little bit about the case. It looks like we have somebody coming in to a general medicine clinic because he's had some abdominal pain previously yesterday evening, apparently. So your doctor, preceptor, Dr. Brown, you're a med student who's working, says, what are some causes of abdominal pain that we don't want to miss? What do you guys think? If you want to put any in the chat, that'd be great. So when we think of somebody, who's presenting with abdominal pain, what are some of the diagnoses that we might want to make sure that we rule out? Great, yes, a GI bleed, stab wound, absolutely, that can always happen. Anything else? What do you guys know about what is within the abdomen? Yeah, gallbladder issues, appendicitis, right? The appendix is down there. Certainly that's something not to miss because that can rupture. Gallbladder issues, you could even have like infection caused by gallbladder issues. So great. Yeah, all of those are some great differential diagnoses and things to be thinking about that we don't want to miss. Let's see, let's go to the next slide because I think, yeah, so general causes of abdominal pain. So the way we break up the abdomen, when we think about the abdomen, there's actually like 9 quadrants essentially that you can think about, but I've just got 4 here on this image. So let's start with like the right upper quadrant. What are some of the organs that are in this quadrant? Okay, so this one we think about the liver, a little bit of the stomach, the gallbladder, parts of the duodenum, some of the right kidney, pancreas, the transverse colon, so the colon that goes just kind of across, transverse, is in the right upper quadrant as well as the left. So what about the left upper quadrant? Do you guys know any organs within that area?
The spleen.
Spleen, great. Yes, wonderful. Spleen, rest of the liver, great. Yes. Say stomach, kidney, let's see. Yep, the other kidney, great, awesome. Okay, so things to be thinking about as far as abdominal pain goes, because if the patient's having pain in a specific location, it might clue us into potentially what could be going on. So what about the right lower quadrant here? Is there anything that you think about when you think about like right lower quadrant abdominal pain? Small intestine, colon, great. Somebody had mentioned the appendix as an issue earlier, like appendicitis. Yeah, great. Okay, so yeah, so large intestine, cecum, appendix, the right ureter even. Okay. And what about our left lower quadrant?
What about liver or kidney disease?
Pardon?
Liver disease or kidney disease?
Yeah, if we're thinking about, again, what some like general causes and etiology of abdominal pain, certainly we can have things like hepatitis, kidney disease, you can have kidney stones, right? Things like that. So all things that we should put on our differential. So this left lower quadrant specifically, here we've got like the rest of the colon, some of the reproductive organs, if you're specifically talking about somebody that is a sex of female at birth, somebody that has like the ovaries are in both the left quadrant, lower quadrant, and the right lower quadrant. So that's something to consider too. Let's see, let's go to this picture here. So here is where they break it up into 9 quadrants. And if you just think about it, if you look here, we can read through, or you can read through some of these yourself about some of the concerns as far as our differential diagnoses go when somebody comes in with abdominal pain. So for example, what this means is like, if they have some upper quadrant pain, it might be, a stomach ulcer, whereas like the stomach ulcer is less likely to present down here in these quadrants, right? Similarly, diverticular disease is very common in the left lower quadrant, where appendicitis is common in the right. But appendicitis, it definitely can spread and become more localized, or it can become more diffuse as well. It can start out diffuse and then usually becomes more localized. But okay, great. So we talked about a few of the causes of abdominal pain that we don't want to miss. I want to encourage you guys to think a little bit outside of the box as far as some maybe extra intestinal, so like things outside of the GI system that could be presenting with abdominal pain. Because abdominal pain is pretty non-specific, right? It could be many types of things. Do you know any cardiac issues of that could cause abdominal pain? Great, yes, AAA, blood clot, wonderful, yes. Even like a pulmonary embolism that gets into the lungs could even have some abdominal pain. So yes, the AA, the AAA is an abdominal aortic aneurysm. So those can like rupture, which is very, that's very serious. Great. And then even like a heart attack, right? An MI can present with abdominal pain. So here are some of the other causes of abdominal pain beyond GI. Here's some GI stuff, but here's some other ones that we want to think about. So acute coronary syndrome. So that's anytime we have like ischemia to the heart. And there's different, types. You can have like full ischemia, in which you have like a heart attack. Or you could just have what's called angina, which is chest pain. So that can also present with abdominal pain. Someone had mentioned like an aortic aneurysm. Certainly that can present with abdominal pain. The PE was mentioned. Appendicitis, diverticulitis, pancreatitis, some of these things were mentioned earlier as being GI causes. You could even have a bowel obstruction, right? When we obstruct our bowel, that's often a surgical emergency. And then ectopic pregnancy and ovarian torsion. So don't forget these two in your patients that are females. So ectopic pregnancy, does anybody know what that means? I believe the fetus has died in pregnancy outside the uterus. Yeah, great, awesome. So yeah, when you have an ectopic pregnancy, it's when the baby or like the fetus implants outside of the fallopian tube where it's supposed to be, or it implants, sorry, in the fallopian tube where it's not supposed to be, rather than within the uterus, right? And so oftentimes it will result in something like a miscarriage or a spontaneous abortion. Okay. And that can be very serious. So it's important to recognize, and even, any female patient that comes in with abdominal pain to the emergency department is definitely going to get a pregnancy test. Okay. And then ovarian torsion is just like twisting of the ovaries around their ligaments. And then it even has something like diabetes can cause abdominal pain. So if you have like diabetes complications such as like ketoacidosis, or a type 2 complication, which is called this hyperglycemic hyperosmolar state. Both of those, which it's not important for you to really know those terms. I just wanted to make a point as far as like metabolic issues can certainly cause abdominal pain as well. All righty. So here's a few other details about the case if you want to read through these before we chat about what we want to do next. All right. Okay, so based on what we have gathered so far from our interview with Mr. Sanders, what are some other questions that you would like to ask him?
Has he ever had gastric bypass surgery?
Okay, yeah, why is that something that you might be concerned about?
I'd be concerned about that because I know there's a syndrome that happens when people get gastric bypass surgery and they eat too much food.
Oh, and when they eat, oh, yeah, absolutely. Yes, you have to be very careful about your diet after having gastric bypass surgery, right? It's going to change a lot. And many times those patients have to have special dietitians and things like that. So certainly that's something that we might want to ask the patient. Great. What are some other questions? Has he any black or tarry stools? Great. So asking about like black or tarry stools will kind of get at, is there any sort of bleed within the GI system? Unable to have a bowel movements like constipation. Was there any blood in the vomit, or what did the vomit look like? Great. Did you take any pain medications for it? Awesome. These are all great answers. Good things to ask. What else about the pain do we want to ask him? So far, we know it started last night and it's gone at this point, but it was really bad last night. The scale of 1 to 10, great, awesome. What kind of pain was it? Exactly.
And where is the pain?
Yes, great. That's another thing too. We just talked about like the quadrants of the abdomen and how, maybe pain localized to one quadrant over the other might suggest, a certain etiology over another. So that can really help us with our differential diagnosis. Awesome. All right. So yeah, some good questions to ask. Location of the pain. Did the pain move? Did it change? Does he have any pain elsewhere, such as like chest pain? Very important, especially when you guys had mentioned, all of those cardiac things were on the differential. And then any additional symptoms. So going through the review of systems and asking about things like constipation, even with the urinary system, is he having any pain with urination, any blood in the urine, all the cardiovascular stuff. So just being very thorough in your questioning. And then two, like, is there anything that he thinks may have caused the abdominal pain? And how is it different from previous episodes that he's had? And then, well, as always, past medical history and social history. All right, so I think this is like our last, big chunk as far as the information we're going to get from the history. So if you guys want to take a look at this and read about it, and then think about how maybe your differential may have changed, what things you might want to add, what things maybe don't seem as likely.
I guess now that he said it was in the middle of the stomach, I'm thinking like either an aneurysm or appendix or gallbladder rupture.
Yeah, so he's saying middle/right side of the stomach. So, upper quadrant, maybe more in that right upper quadrant, maybe in the middle a little bit, kind of non-specific. But yeah, with like a rupture of an aneurysm, do you think that he would be fine? Like, do you think he would be okay just sitting here? Or do you think it would be something that would require like emergent care?
I think you might need a CT to determine that, since it is
Yeah.
pretty recent, like the pain. So
Mm-hmm.
hopefully it's like not super bad. Maybe he could stay and then go home and like schedule surgery in a week, but he
Yeah,
seems
if
to be
this
okay
is, oh,
now.
sorry, go ahead.
But he seems okay now because he's not in pain, but I think we should check. So it's like, make sure
Yeah.
it's captured. Thank
Yeah,
you.
if there was a rupture, then certainly I don't, he would be decompensated, his blood pressure would be low. This would definitely be something where he'd be going into the emergency department. So maybe, it is certainly true that he could have an aneurysm at some point that we just don't know about. So that's a great thought. But as far as it just being ruptured already, I think that's less likely. Just because he's here, he's sitting, talking to you, all of those kind of things, but great thought.
Thank you.
Somebody had said probably a gallbladder issue since it was in the right upper quadrant and came on after a burger meal, greasy. Yes, great, awesome. So right upper quadrant, we're thinking what's in those areas. Gallbladder is in that area. Maybe something's wrong with it, and especially with after having a meal. So right, the gallbladder is helping with digestion because it stores bile and then releases the bile to help us digest like proteins and fats and stuff. So awesome. Okay. Great. So here's some of his past medical and social history. All right. Anything that sticks out to you about his medical and social history?
He seems to have a history of heartburn with the Tums and the GERD. So that's definitely sticking out to me.
Mm-hmm.
I
Yeah,
also
great.
think, thank you. Yeah, also apparently like his diet, because he does eat a lot of fats. But his cardiac history
Mhm.
is good though.
Yeah.
Interestingly.
Let's see in the chat, 10 to 12 beers. Yeah. So awesome. So I think it's really important to notice that he has a history of gastrointestinal reflux disease. Remember, he did mention that this kind of didn't really feel like his heartburn. He's had heartburn before, but Tums didn't really help. So maybe it's heartburn, maybe it's not. Still important to recognize that he has this history. And then someone had mentioned, he drinks 10 to 12 beers, which I think is a really important thing to talk about, because when you have a patient like this and they're coming in and they have this concern, but then you take the history and you learn like something about alcohol use, it's like, do you address that now? Is it more appropriate to address at another visit? And so there's a quick thing that we can do with patients that, we might have concern for alcohol abuse. And that's called an audit C, excuse me. Oh, wait, actually, that's coming, but actually, we'll get back to the physical exam in a minute. But it's called the Audit C, and it's really easy because it's just 3 questions. And when you screen people, if they get a score greater than a 5, then that means that they should probably be evaluated more thoroughly for something like alcohol abuse. Okay. So he answers for the first one, how often did you have a drink containing alcohol in the past year? He says 2 to 3 times per week. So he gets 3 points for that. How many drinks containing alcohol did you have on a typical day when you were drinking in the past year? He says 3 to 4. So that's another one. So that's 4. And then how often did you have 6 or more drinks on one occasion in the past year? And he says monthly. So that's 2. So he gets 6. And so I think it's really important to remember that. And this is something that we should probably address at another visit, specifically a visit 4, asking him questions about the alcohol abuse. What do you guys think about that?
Yeah, I think so too.
Great. It's sometimes easy to like brush these things off, but I think it's really important that we take the time and, in a non-judgmental way, of course, like with our patients and talk with them about these issues, see if there's anything else going on that they want to talk about in their life, Okay. But getting back to more of just that, the abdominal pain that he has. So what aspects of the physical exam would you guys want to pay most attention to? So we want to make sure that we definitely look at the abdomen, right? Yep. So abdominal palpation, is the pain reproducible? Great. Yeah. Is the pain reproducible? Is there any like guarding or rigidity? Right? Have you guys heard of something called a surgical abdomen?
I think so.
Yeah. When there's like an emergency, like for example, let's say there was a small bowel obstruction or something like that that got really bad, and you have guarding, rigidity, you have maybe some even peritonitis, which is like inflammation of the peritoneum. That's called like a surgical abdomen, and you have to be, really honestly undergo like urgent surgery at that point. So great, awesome. Here is the physical exam. So read through this and then let me know what you think about the findings. Okay, anything abnormal you guys notice about these findings?
His blood pressure's a bit high, but not so high.
Yeah.
Yeah, everything's mostly normal.
Yeah, mostly normal. It looks like, he has, slightly tachycardia, but no, abdominal findings. Yeah, heart rate 90. I mean, a little bit over 100 might be a little more concerning, but yeah, usually people when they're just resting might not have a heart rate like that. High BMI, yes, yeah, he falls into that obesity, category with the BMI. So that could put him at certain risk factors. Or is a certain risk factor for different diseases. And then, yeah, most notably though, the abdominal exam is pretty unremarkable. Okay. Does anybody know what Murphy's sign and obturator sign is? So these are both signs to check for appendicitis. Now, I know this patient had an appendectomy when he was younger, which means he had his appendix removed, so probably doesn't have appendicitis. But still, for somebody coming in with abdominal pain, it's really important to do these exams if you do have a high suspicion for something like appendicitis. And so starting with Murphy's sign, really what that is you ask the patient to take a deep breath in, and while you're palpating their right upper quadrant. And when they take a deep breath in, if pain occurs when that gallbladder, like the inflamed portion touches your hand, then that's when Murphy's sign would be positive and you would have a high suspicion for something like cholecystitis. Okay. And then psoas and obturator signs. So psoas and obturator signs are specifically for appendicitis. And so psoas sign is going to be when you take the person's leg and you basically flex their knee. So you flex their hip and you start to move it. And if they have, irritation or pain with that, then that could be indicative of appendicitis. And similar to this muscle, the obturator muscle, which is in that same area too. So these are for appendicitis, and then this would be for something like cholecystitis. Okay. Any questions about those two exams? Okay. So the principle of all of these would just be because there's inflammation that's happening. So both within the gallbladder here with Murphy's sign, and psoas and obturator with the appendicitis. I think previously when I introduced this slide, I wasn't looking at this one, so I said these were just for appendicitis, but Murphy's sign is specifically for cholecystitis, so inflammation of the gallbladder. Is McBurney's point different than obturator sign? Yeah, great. So McBurney's point is different than obturator sign, but it is still a test that you would like to do that can clue you into whether or not you have appendicitis. So that's like a point of the right lower quadrant where the tenderness will be like really maximal when you have something like appendicitis. So it's more like palpating that area and seeing if you have tenderness in that area versus the obturator sign with like moving the leg and irritating that muscle. Great, thanks for bringing that up because there are definitely other classic exams that we can do for appendicitis. All right. So to summarize, this is what we know about our patient. So what are our top differential diagnoses now with some of the information we have? Knowing that, our exam was pretty grossly unremarkable, I would say. So are we as concerned about some of those more urgent causes of abdominal pain?
No,
Yeah.
because I think he would have had a positive Murphy sign if he had appendicitis. It's not that his gallbladder ruptured.
Yeah, so with the Murphy sign, yeah, probably maybe not cholecystitis or like the inflammation of the gallbladder. And yeah, the appendicitis, obviously he doesn't have an appendix, but his exams were, we still did the exams and they were negative as well. So good. So what are we thinking then? Someone had mentioned something still about the gallbladder in the beginning. Cholecystitis or inflammation infection from like a gallstone lodging itself in the cystic duct. That's what that's from. But just because we don't have cholecystitis doesn't mean something might not be going on with the gallbladder. So what do you guys think?
I think I'm likely it's the gallbladder, either the
Mhm.
gallbladder, spleen, or diverticulitis,
Okay.
or his aneurysm now.
So here's some of the things just to think about. Pancreatitis, gallstones, just having a gallstone in your gallbladder can cause like intermittent episodes of pain like this. Having an inflamed or infected gallbladder, having an ulcer, but of course he doesn't have a history of like any bleeding with that. Even hepatitis, but we didn't see anything like jaundice on examination, which is where you get like yellowing of the skin or of the eyes. And then less likely is like appendicitis, probably less likely his GERD, myocardial infarction, so heart attack. His cardiac exam was normal. Seems like he doesn't have that many risk factors besides, hypertension and obesity. And then less likely a kidney stone. On exam, he didn't have tenderness in that area of the kidney. He also didn't have any urinary symptoms. All right, so what further testing is needed? What do you guys think?
CT ultrasound?
Yeah, let's do an ultrasound. Yeah, an ultrasound of the right upper quadrant sounds great. Abdominal CT is certainly something we could consider. I think maybe doing like an ultrasound first would be helpful because then maybe we can avoid doing the CT, but it's definitely something to consider. What about, do you guys want to do any labs? Urinalysis? Great. Yes, urinalysis would be good. He doesn't really have urinary symptoms, but we could certainly, ask him just to make sure there's not, an infection going on or something like that. I mean, that's something we could add on. Liver function, enzymes, blood work, that's all great ideas too. Great. Okay. So yeah, we'll just do some general labs. So like a CBC, so complete blood count, complete metabolic panel with the liver enzymes and lipase. Does anybody know what lipase is?
I believe it's a type of enzyme that's used for helping something in the body.
Yeah, so
believe.
this is an exactly. So this is an enzyme that comes from the pancreas. So when we have like pancreatitis and damage to the pancreas, can release that enzyme and it can drive up that lab level. So it's helpful when we're looking for something like pancreatitis. And then abdominal ultrasound is a good idea as well. So yeah, we don't really want to do an abdominal x-ray, or we don't really need to, because really all that would tell us is there something like a bowel obstruction? Is there like free air under like the diaphragm or something from like a perforation? And none of the exam findings really suggested either of those. So we can probably hold off on that for now. Okay. All right. So here are our results of the abdominal ultrasound. What do you guys see? And all the labs were within normal limits. What do you guys see in that gallbladder there? What does that look like? Any ideas?
Stones. Those look like stones.
Yeah, they do look like stones, huh? Yes, exactly. So these are stones. Here's what the reading said. The ultrasound reading said normal size gallbladder, no wall thickening. There are 4 to 5 stones with shadowing. So shadowing is when the patient is laying supine in the supine position. Gravity will cause these stones to kind of fall posteriorly, and you see like this darker area under the stones. So that's shadowing. And it says there's no dilation of the common bile duct. Does anybody know what that means or why that might be important?
I guess that could mean maybe they're not so big, like they need to be taken out yet, or like they're not causing too much damage.
Yeah, not causing damage. Exactly. So like there's no stone that has lodged itself specifically in the common bile duct. And we will talk about like what that looks like as far as the biliary system in a couple slides. But yeah, so we don't really have as much concern that it's lodged itself there. Great. What about the no wall thickening? So thickening is like a sign of inflammation. So this would be like more suggestive of something like cholecystitis. Okay. Great. So let's talk a little bit about the pathology of the biliary system. Okay, so bile is made in the liver and stored in the gallbladder. It's important for breaking down proteins and fats during digestion. But we can have an issue with the gallbladder. Specifically, we can have gallstones, which are when we like have hardened deposits of that like digestive fluid that like forms. And most times it's because like there's too much cholesterol in the bile. If there's too much cholesterol, then there is bile to dissolve the cholesterol, then they can precipitate as little stones. Cholesterol stones are like yellow in color. And they're like one of the most common. And then there are another type of stones, gallbladder stones called pigmented stones that are from excess bilirubin. So bilirubin is a byproduct of red blood cell breakdown. And when you have too much of that around, you can be at risk for gallstones, pigmented gallstones. Okay. So some risk factors for gallstones, being female, being over the age of 40, obesity, high fat, high cholesterol. So similar to, how this guy was having, a lot of cheeseburgers, hamburgers, whatever he was having, beer, things like that. Pregnancy and even losing weight very quickly can prevent the gallbladder from emptying properly. That's one that I always forget about. That can be a risk factor. And then diabetes, family history, that sort of thing. So let's look at here like the biliary system. Okay, so bile is made within the liver and it flows through these little intrahepatic ducts and then through the big hepatic ducts into this common hepatic duct, where it will then go into the gallbladder to be stored until it needs to be released to help with digestion. And so this guy is called the cystic duct, specifically the one that connects to the gallbladder here. And then when we want to do digestion, we will release some of that bile. It will go here, like through the rest of this, kind of the rest of this trail here. And then it will get down to where the pancreatic duct meets the bile duct. And this is called the ampulla of Vatar. It's whatever, you don't need to know that name. I didn't pronounce that right. But then this will empty within into the intestine and help with digestion. Okay. So when we have gallstones, we can have them staying in the gallbladder. And when they stay in the gallbladder and they intermittently, so like sometimes they'll kind of come up here and lodge themselves in this cystic duct, and they'll just stay there like for a little bit, and then they'll fall back down. That can cause like some intermittent abdominal pain. Okay, that comes and goes, and usually like associated with having, after a meal and things like that. Now, if that gallstone goes up and it lodges itself in the cystic duct and it stays there, and then we get inflammation and infection, that's when we get cholecystitis of the gallbladder, okay? You can imagine then those little ducts as well can come along and they can even block things like the common bile duct, the common bile duct here. They can block really anything along the way. You can have something called an ileus where they get into the intestines and they actually cause a blockage there. So lots of things that can happen from having, gallstones. Okay. So biliary colic specifically, what I had mentioned earlier was just that, those little gallstones coming up and transiently blocking this cystic duct. That's called biliary colic. Cholelithiasis is having gallstones. And when you're symptomatic, that's called symptomatic cholelithiasis or biliary colic, okay? And that's when the gallstone temporarily blocks the duct. So it kind of fits what our patient has been, concerns of, right? He's been having these intermittent episodes of like severe abdominal pain after eating, but then now he's fine, right? So pain is also typically within the right upper quadrant because that's where the gallbladder is. And then about 70% of people, though, that do have this issue eventually develop cholecystitis. So maybe that gallstone will come up here and block and then eventually cause inflammation, infection. So if you don't treat it, it might eventually become more problematic. Okay. So then how do we treat it? What do you guys think?
Watch what either happens to the stone or medication now at this
Yeah,
point.
maybe great. Yeah, we do
Yeah,
have a
medication.
medication that can
Okay.
help.
All right. Or wave therapy, like wave frequencies to break it up.
Oh, great.
Thank
Yes,
you.
that is something that I didn't even add in there. So great. Yes, there is something that you can do to break it up. I think big take home message here is that because it's such a high likelihood that they will go on to develop something like cholecystitis or another complication of having gallstones, what we will do is refer them for a surgical consultation to have an elective cholecystectomy. So that just means on their own time. So it's scheduled. It's not an urgent surgery, but it's a scheduled surgery where they will have the gallbladder removed, specifically if they've been having, these symptomatic episodes. If they don't want to do that, or, they want to wait for a bit, we do have a medication that can sometimes be used to help like dissolve the gallstones, but it's just more so used in the short term. Okay. So what do you guys want to counsel this patient on? What would you like to tell the patient as far as the plan?
I guess I would say they should cut back on eating anything with like too much fat or like cream so that we do not upset the stones. Maybe consider reducing their alcohol consumption or eating more vegetables.
Yeah, great. All of those things to counsel him on would be awesome. Yeah, I agree. So kind of trying to decrease those risk factors, right? So diet could help a lot. I think, he has to come back at some point to discuss, the alcohol abuse or the alcohol use, to see if it is abuse or dependence. And so making sure we do that too is important. And then also scheduling him for like a surgical consultation to see if he does want to get the gallbladder taken out. I think those are all reasonable options here. Okay. So you place a surgical consultation and schedule him for a follow-up visit with you in 2 weeks, and that's when you will address his alcohol use. Great. Okay, so any questions about this one? It was a pretty laid back case, but it's often, when people come in with these intermittent episodes of abdominal pain, many times it is biliary colic or it is these gallstones. And when they end up having to be admitted or when they come in, they're very, very sick, it's often a complication of those gallstones if they've got right upper quadrant pain. Okay. All right. So thanks for participating. You guys can go ahead and try to do the quiz. And then you can always retake it too if you want to. And then in a couple Wednesdays, we will be coming back. Thanks for joining.
Thanks again for an interesting session.
Thank you.
Yeah, thank you so much for hosting the session. It was really great.
Well, thank you guys all for participating. I hope you have a great rest of your week.
You as well.
Thank you. Nice meeting you.
Bye.